So I wanted to just make sure I hit on, there was a couple muddy points where they were pretty good looking at some of lithium side effects, and are tremors something that are constant, and it can be a little different depending on the patient, and it can actually be dependent depending on the release of the drug for levels. So there may be times where that tremor can wax and wane a little bit, depending on, if you've got the peak of the lithium or the trough. But they can also be constant. It's really going to be patient specific. Most of the time when we're talking fine motor hand tremor, what I mean, those are postural tremors. So if you were to kind of have your hands down and not be moving, you may not notice it. It's when you start actually supporting something that you would start seeing the hand kind of shake a little bit, okay? And looking at lithium in terms of toxicity as well, it really is tied into levels for sure, but just remember that just dependent on, regardless of the level, even at lower doses, you still can see some of the side effects that we normally think about at higher levels happen earlier. Patients can be more sensitive, and that's one of the reasons why if you start out on lithium, especially too high of a dose, you can't just assume that you're going to start everybody and titrate them up to a certain level, okay? So it generally, though, they are correlated. For example, above 3.5, we know that's pretty much going to kill your kidneys. You might have somebody that will have renal impairment from that, even at therapeutic levels. Probably won't shoot their kidneys out if they don't already have some predisposition there, but it's not impossible. We know that it can be a nephrotoxic drug, okay? Any other questions I can answer right now before we kind of jump into today a little more? No? Okay. Again, I really do like that discussion board. Any questions on there? I know we had one. I put an example of how they'll decanoate. If that's still not enough, I promise we'll go over it during the review as well and make sure you guys are 100% clear on that. I put some rule of thumb principles, whether you're looking at conventional or loading dose on there. Just kind of remember your baseline, never give more than 100 milligrams as that initial injection, and then you come in and give the remainder 3 to 7 days later up to 200 milligrams max. So I'll go through that again in detail and make sure you guys you're in the clear. The other thing is I had somebody who came in and astutely told me that there is a discrepancy in my slides compared to the book, and I am happy to tell you the book is wrong, okay? The book is completely and totally wrong. If you're looking at the chart of drugs that shows paliperidone must be taken with food, okay? Now, the drug company for paliperidone will come in and tell you, if you look at all the studies that have been done, they didn't really care when the drug first came out. But what they found is that ghost capsule, since it has that bird hole on one side, it has that osmotic pump that slowly allows release, that they like you to take it in the morning, because if you have a giant bowel movement in the morning, that kind of pushes the drug through a little faster than they would like. So it's better to actually take that drug in the morning, and the way it travels through the GI tract, it makes a little more sense. But technically, that doesn't mean anything to do with food. That's the only thing I would speak to that may not be addressed and why people sometimes think of taking it in the morning with breakfast. The bigger thing is that comment, and I'm going to write this strictly to the editor of that chapter, is that should be mentioned for Latuda, that it should be taken with food. Latuda has to be taken with 350 calories of food or more, or the bioavailability is garbage, okay? It's less than 50%, right? So that is true. The other thing that was pointed out was fluphenazine dosing. So if you look at the book, compared to the package insert, compared to lexicon, compared to micromedics, you might find, and you will find, actually, 4 different answers on how to dose Prolix and decanoate. What I have done is looked at the general dosing parameters that surround the drug, instead of making you memorize 3 different ways you can dose Prolixin. Rule of thumb is, if you look at the conversion of the drug, 10 milligrams of the drug equals about 12.5 milligrams of the decanoate. So you times whatever they're taking orally by 1.25 and you get your decanoate. If you look at studies, everything shows that it can be given between 2 and 3 weeks. Some say it can even last up to 4 to 6 weeks. Okay, all of the things that have been out there, a lot of the dosing parameters say 3 weeks. So you boil that down to what's done clinically. Okay, so this may actually be different than the Stimmel method, which DePiro references at 1.2 up to 1.6 every 4 to 6 weeks, giving it once a week, and then after that you give it 2 to 3 weeks, kind of as I was saying before. Okay, that's really confusing. let's just boil it down to long story short on how most practitioners are going to dose it, which goes with all of those dosing parameters in mind. What you're going to see is take their dose, it's by 0.125, okay? And you can dose it every 2 to 3 weeks is the average dosage that's been recommended. It's an old drug that's been dosed like that for a long, long time, okay? The reason I lean towards the 2 to 3 weeks when we talk about it clinically, and most of your psychiatrists will look at it that way, is because instead of dosing it every single week, which outpatient-wise may or may not be feasible, okay, for your psych patients, the studies were all done starting out the drug in 2 weeks and then showing that you can actually do it for 3 weeks, and some are now saying you can actually see the drug have effect for 4 to 6 weeks. That's where all that confusion comes from. So the reason I'm doing that is I'm trying to boil it down and make it simple. 1.25 every 2 to 3 weeks. Remember, you have to orally supplement for the first week and give that second dose a week later. It clears up a lot of confusion, I think, okay? You might not find that as a direct citation in your micromedics or lexicon, but it's kind of pulled from the 4 different dosing methods that are out there for Prolixin for your student learning, okay? Does that clear that up? Or did I make it more confusing? Okay, but if you just basically look at exactly what I have in that slide there, I feel like that one's a little more straightforward. You don't have to think about the loading dose as much. You don't have to worry about the range of 10 to 15. That's why I basically just say the direct conversion is 1.25, okay? All right, so moving into our last bit of fun with our bipolar drugs today. We're looking, I just want to touch base, and because I know we kind of wrapped up with valproic acid, again, another drug, a lot of side effects, maybe not as bad as your lithium, right? But still a lot to worry about there. Was there questions on valproic acid before we jump into carbamazepine today? You guys good on that? The one thing I will say is that when we are looking at side effects here, and you do see tremor listed there, I went through this a little bit yesterday, but it's not, again, that fine, coarse hand tremor that you see. Usually it's another postural tremor that often happens in patients, but it's not like that fine tremor. It's usually like a little more discreet, okay? Not something that I'm going to sit there and specifically task you on fine hand tremor versus coarse tremor I want you to think of with your lithium. But tremor in general is a side effect, and it can be seen in up to about 0.25% of your patients. And it can happen after somebody's been on it for longer durations of time. It can happen right away, anytime you have a dosage increase. But sometimes you see that crop up later as well. And it's not always as directly correlated to the levels. Higher levels, higher chances, but sometimes it's just exposure to the drug overall, okay? So I wanted to make sure I made that point clear to everybody. Is there questions on that? No? All set? All right. So, again, don't forget polycystic ovarian syndrome in this. Again, that larger study that was done in females, up to 42% of females. So the fact is that, again, even when we talk about epilepsy, valproic acid is listed as first-line therapy for a lot of those. It's listed as a first-line therapy in mania for bipolar. Please remember, if you have a female of childbearing age, you don't want to have to worry about things like amenorrhea that goes along with polycystic ovarian syndrome difficulty, and if someone does want to start a family with reproductive issues, those types of things. So I'm not going to say we never use it in females. We do. It's a very effective drug, but it's not going to be my first-line option in female patients of childbearing age, or even younger than that, right? If we have younger women, even whether, again, you're going to hear me say the same thing when I talk about epilepsy. That's often a childhood onset. I don't like seeing it in female children either because of the same issues with development. Okay? All right. So moving into carbamazepine today. So carbamazepine, again, remember, is by nature an anti-epileptic drug. That was its first indication. It is, if you remember, any drug for causing drug interactions. This is usually the one we normally think of as your primary major inducer of many of your CYP enzymes, right? Especially your 3A4. So that's where, as a pharmacist, you really do need to know carbamazepine because of the drug interactions more than anything else, right? In terms of its efficacy for bipolar, It is still looked at as a primary treatment. About 60% of your patients, you're going to see efficacy for acute treatment. Okay, does have, again, remember lithium isn't as good in rapid cycling and mixed states where carbamazepine and Depakote are. You also are going to see for prophylactic therapy, 60 to 75% of your patients are reported to show benefit to help preventing them from cycling. Time to response, similar to what you have seen when we talked about lithium and valproic acid as well. It can be a few weeks, 1 to 3 weeks. All right, so again, not going to necessarily, even though it can be effective in acute mania, have as rapid of an onset to show it's going to pull them out of an acute mania. Also, when we're looking at dosing of this drug, same as I've said for our lithium, same as I've said for our Depakote, ultimately I want to look at the range because of toxicity levels. So the range is going to be 4 to 14, or 4 to 12. Some will go up to 14, but generally I want you guys to remember 4 to 12. That's the standard that almost the vast majority of labs across the country go with. Okay, so 4 to 12 is your plasma concentration. Steady state is going to be pretty similar to what you would recommend for lithium, 5 to 7 days. So this is kind of where, if I have somebody on Depakote, I can draw a level in 3 days. If I have somebody on lithium or carbamazepine, you notice the similarity there is 5 to 7 days. Okay. The big thing with this drug, if you don't remember it from pharmacology, you may have even touched on it a little bit in other classes at some point in time when you're learning about your isoenzymes with pharmacology, patho even, is that this drug, as much as it's a major inducer of everything else, can induce itself, right? So after a month of being on this drug, when you get to a therapeutic level, it induces itself to bring your levels to about half of what they were before. You have to remember that because you are generally going to have to make a dosage increase at that point in time, okay? So that is why it's really important to look at getting blood levels biweekly for the first 2 months because of that autoinduction. And then after that, once things stabilize, you can look at it every 2 to 4 months if necessary, okay? So don't forget, about a month in, autoinduction happens especially at the peak point of 4 to 5 weeks. That doesn't mean it's not happening sooner than that. It starts happening within usually the first week of therapy. It can start, and then it kind of builds up, and you see the peak of that between 4 to 5 weeks, right? So that's when it's most critical. So don't forget to dose increase at that point. Okay, so as I mentioned, primary inducer of CYP 1A2 and 3A4. And if you think about which medications that usually have interactions across the board for CYP isoenzymes, those are probably 2 of your biggest, right? 3A4 is definitely the largest class of drugs that are metabolized through that pathway. 1A2 is right behind that, okay? So remember drugs for 1A2, like Luvox, that's an inhibitor. Drugs that just have, metabolism through that. When we talked about even in Parkinson's disease, ropinirole is a 1A2 metabolite, okay? Or it needs 1A2 metabolism. So something like carbamazepine coming on board is going to affect other drug levels for sure. So especially with critical drugs, this is where we run into problems and pharmacists have been sued over, okay? Because of the fact you're giving them with a lot of times critical drugs, like birth control. There was a story, and I say this so you remember it, okay? There was a story of a pharmacist some years back that did not counsel a patient on the fact that they were on an oral contraceptive and started carbamazepine, and they got sued for child support of that child after it was born because it decreased the efficacy of the oral contraceptive. They won that lawsuit, okay? Don't make that mistake, all right? Remember, it's going to have major drug interactions. You want to pay attention to drugs like birth control, like antibiotics, like other anticonvulsants, okay? Your anticoagulants like warfarin. It's going to increase that metabolism. Okay, so baselines, again, this looks pretty similar to what you've already seen. Now, again, I'm not looking at all of these to necessarily be an issue of the drug causing thyroid function test abnormalities like lithium does long term. Okay, but you always want to start with a baseline and make sure that those are where they need to be. Of all of them, this one, though it's not as much of a chance as, and you'll hear me mention trileptal, it's got some literature supporting its use, other places it's not as strong, but oxcarbazepine, which is kind of like the, in terms of seizures, we like that drug a little bit better because you don't have to plasma monitor, less side effects as a whole. That drug has a higher chance of causing hyponatremia. Carbamazepine has a little bit less of a chance of causing hyponatremia, but it's still there. So you want to remember when you're thinking about your tests, electrolytes is a good one to measure for baseline and follow-up as well, and liver function tests. This also has been known to be hepatotoxic, and sometimes you can see some increases in liver enzymes when starting the drug or titrating the dose upward as well. Okay? So liver function tests, if you're going to remember of all your tests that you're going to say, okay, someone's starting carbamazepine, I noticed that if we're drawing blood on them already, what else do I want to draw with it? That would definitely be the ones to go for. It would at least be doing something to measure the sodium, so your Chem 7, 14, which also includes the liver function tests. Okay? Remember we talked about that complete metabolic panel. Your Chem 14 includes your liver panel, so you can do that all in one. Okay? All right. So now we're looking into our overall side effects. You'll notice some similarities with Depakote as well with this. The drowsiness, the dizziness, the double vision can also be present here. GI side effects are usually pretty common, especially when starting the medication out or increasing the dosage. Most patients will report, about 15% of patients report that. You can still see rapid and photosensitivity with this drug as well. Not as common as actually valproic acid and definitely lithium as well, but it's still considered a common side effect, and you'll see patients reporting photosensitivity, especially to sunlight. And then I mentioned the hematologic. So 25% of patients, again, when we're looking at this, you can see a decrease in white blood cells. It's not usually something I'm really ridiculously concerned about unless they already are low, kind of to start with in the beginning of things. So kind of keep that in mind. And then there is a rare risk of, because again, even though it's a transient increase in white blood cells, higher risk for actually causing agranulocytosis. Okay, so remember that basically wipes out your white blood cells, and your absolute neutrophil count kind of goes down with that. And aplastic anemia is another one. So kind of keep that in mind. Baseline monitoring for follow-up, not a bad idea to also do a complete blood count with that. You heard me mention hyponatremia again. Rarely you might see SIADH, syndrome of inappropriate thyroid hormone, and the hepatologic we already touched on again, so the liver function tests are a good idea. This one, as well as your Depakote, isn't, if I were to say it was an apples to apples comparison for neural tube defects, Depakote's probably a little worse, but this is not that much better. We're still talking category D. It doesn't have as much of an effect on IQ of exposed infants as your valproic acid does, but it is definitely known to cause neural tube defects. A lot of your drugs, and we'll talk about this a little bit more when we talk about our anti-epileptics, because it is more of a chronic problem in pregnant women who are of seizures, and we may not be able to get them off their medication. Is similar to some of the issues we have here, is that your medications have some folate antagonism to that. And that first trimester of pregnancy, you heard me mention yesterday with valproic acid. Anytime that you have folate antagonism in that first trimester where the neural tube development is going on, that often causes teratogenicity. So you will also see spina bifida associated with an increased risk to mothers taking it during pregnancy to their infants. Okay. So the other is that you can see in the fetus cardiovascular complications, and urinary tract defects have also been noted in fetuses exposed to carbamazepine. Is there any questions on carbamazepine before we move on to lamictal? Guys good? Okay. So lamotrigine. Now, this drug, remember, it has FDA approval for maintenance of bipolar 1. But if you look at a lot of the post-marketing effectiveness and a lot of what the clinical guidelines say, you see the effectiveness of lamictal in the acute treatment of mood episodes has not been established. So you're not thinking acute like we've just talked about for valproic acid, carbamazepine, and lamictal. You're thinking more maintenance therapy for that. And it's not as effective in bipolar 1 as it is in bipolar 2 overall. Okay, we definitely see more studies. Kind of that was that question I had asked earlier yesterday. I believe it was that we went through, and lamictal has got the most studies showing usage in bipolar 2. If it is someone who is acutely manic, it can be used as an adjunctive agent, but you're generally not going to look at it as monotherapy. Okay. We also have studies that go out a little bit longer than some others that have shown stabilization after their acute period of illness, up to 18 months that this shows benefit. So those longer studies, we like those types of things showing that we can, potentially prevent the cyclical nature of the disorder. And then the time to depression or manic episodes in those studies has shown that it is prolonged. All right, again, if you remember I mentioned lithium and all the horrible things with lithium. You need to know lithium. We spent almost the whole class on it, right? I don't want you to forget from today's lecture lamictal. I want these images, as disgusting and awful and horrible as they are, burned in your brain, that there is a clear dose correlation here. I want you to know the dosing of lamictal because of specifically this. It's more common in pediatrics than adults, okay? And you will see this drug even used for bipolar agents in kids. It comes down to as soon as you see a rash, period. Usually it's in the abdominal area when it forms. But as soon as you see a rash, you cannot give this drug again, because of the risk if you continue to give the drug of Stevens-Johnson syndrome. Again, what that is a sloughing of all the mucosal membranes in your body. So your GI tract, your eyes, genitourinary tract, you can see in later stages, especially skin sloughing off, incredibly painful. The fact that it affects the eyes often causes blindness, not always reversible, and often deadly. Okay? Very, very, very severe causes to the point where you get Stevens-Johnson syndrome and it causes toxic epidermal necrolysis, and you see the tissues start dying. That's when you start seeing some of these black spots kind of pop up. That's tissues that are now dead. So do not forget the fact that this relates to dosing. Okay? You are going to start out low and titrate exactly according to the manufacturer's recommendations. There is a reason this drug comes in numerous starter packs. Okay? So, that being said, when we go through the dosing in just a minute, you'll see a chart. You notice here for serious, the fact that if the rash occurs, you have to stop it right away. Do not forget that, okay? You'll notice the serious ones I've highlighted in another color that's showing up really ugly on the screen up here. I'm sorry about that. Hopefully you're seeing it okay on your printouts and your laptop in front of you, but I'll remember not to use yellow on a white slide. That's pretty ugly. So when we're looking at the common side effects, other common ones that a lot of patients, same as the others, you got your GI side effects, nausea, vomiting, abdominal pain, your normal neuro, your central nervous system depressants, asthenia, ataxia, your coordination issues, dizziness, headache, kind of all the things you expect. It does have some incidence of tremor, also reported as a common side effect. And then we're thinking vision, similar to carbamazepine. You can see some diplopia, double vision, okay, and some blurred vision. Interestingly enough, it's reported to cause anxiety and depression, though we normally look at it as treating some of our depressive side of the illness as a common side effect. So kind of keep that in mind. One med might not be right for everybody. It really does have some decent evidence behind it for bipolar 2 patients, more on the depressed side, but it doesn't always work. It can actually make it worse in some patients. And then it is category C for pregnancy. They've actually, I specifically put, Australia has a little bit different in how they classify their pregnancy categories, but it's interesting to look, the ones that are category C, I always like to look at the evidence out there for what we do know, and that is why Australia has actually marked it as D1, because there has been an increased incidence of cleft lip that have been seen in children that are exposed, and that also is Ironically enough, decreased folate has been shown in rat pups when they've done studies, so that shouldn't be too much of a surprise with some of the teratogenicity with exposure. I will say overall with the three of them, again, it is a category C. We have had plenty of women who have been pregnant and been on this drug and had completely normal babies. You don't know which ones it's going to be that are going to have a side effect of that. And sometimes, I don't have it mentioned up here, but there is also sometimes some skin, it's almost like these red striated marks that kind of go across like the skin in some infants that have been exposed. So that may be more of like a toxic side effect in the infant that's been exposed to. So category C, know that there's some teratogenicity to it. Of all of them, you will still see sometimes this being recommended throughout pregnancy, and most of the time it's better than some of the other options. Okay, so here's the deal with the dosing chart. I'm going to try and make this as simple as possible for you. Monotherapy, if you think about where you start out for monotherapy, I want you to remember you start out at 25 milligrams daily with this drug. Okay? This is meaning no other drugs on board that cause drug interactions. And it kind of makes sense. You go from 25 milligrams a day for the first 2 weeks, 25 milligrams twice a day for weeks 3 and 4, and then 25 to 50 milligrams thereafter. And this is doing it on this projector for me again. But, and I checked this as well before I came over. But this part down here, so going up to your average maintenance doses, the thing is that start low and slow titration up. You'll notice when we look at valproic acid, you chop that in half because of the drug interaction there. That, of all of them, is the most dangerous combination. Now you notice there's a dosing pack for specifically valproic acid in lamictal. If patients are on concurrent valproic acid, it comes in that blue pack that specifically shows you every other day dosing for that first 2 weeks, and then you get to 25 milligrams a day, and your maintenance dose is half of what it is for monotherapy. And then when you look at an enzyme-inducing anti-epileptic drug, that's what EIAED, you see the carbamazepine, phenytoin, phenobarbital, one of those drugs you normally think about for that. Okay, you basically cut it in half. Makes sense. It's kind of increasing the lamictal concentrations. It's an inducer of those. Okay, so if you remember anything else in regard to lamictal, because of the Stevens-Johnson syndrome, remember, do not forget about the drug interaction. Valproic acid can double the concentration of lamictal. Okay? If you titrate that too quickly, or you don't start with a starter pack and kind of do that haphazardly, much higher risk of causing the rash and ultimately could lead to Stevens-Johnson syndrome. Okay? And this is kind of just the picture of your dosing packs. So again, you've got your valproate, where you start out 25 milligrams every other day. You've got your regular, and then you've got your enzyme-inducing agents. Okay, so don't forget this chart. All right. So you'll notice that your 500 to 600 milligrams of your maintenance dose when you have an enzyme-inducing drug is definitely higher. The other thing to remember with that is say that they are on carbamazepine and phenytoin, and you decide to all of a sudden, take away the carbamazepine. You have to remember that you have to dose reduce your lamictal too, because you don't want them to be on that higher dosage. Okay. So that's where the interactions come in. It's so important like that. Okay, in a patient experiencing mania, which of the following has the fastest onset of action? So we touched on this a little bit before. So who says Risperdal? Okay, what about lithium? What about valproic acid? What about carbamazepine? Okay, so a couple here and there for each of them, but Risperdal is actually your answer here for the reason that when we look at someone experiencing mania and having psychosis, okay, you need to treat it with an antipsychotic to kind of bring them down from that out of touch with reality psychotic episode. Your valproic acid, your lithium, your carbamazepine will all treat acute mania in most patients within 1 to 3 weeks, right? It's kind of the range, some are 1 to 2, and you're looking at carbamazepine 1 to 3. But I don't want to wait 1 to 3 weeks if I can help it. So remember, that's where your antipsychotic comes on board. So that's why risperidol is the answer. Now, it might not be what I use for long-term maintenance. Could come off of that and look at another drug for maintenance. Or it could just leave them on risperidol. But oftentimes in patients, in terms of cycling, we know that the lithium, valproic acid, and carbamazepine has got better results. So when you hear me go in and we're going to talk about our antipsychotics, they are approved as mood stabilizers. They are effective as mood stabilizers. If you have somebody who has an issue with cycling a lot or severe episodes and you really want to look at what's most evidence-based for efficacy for maintenance therapy, that's where those 3 drugs are your primary look for that, okay? Lithium, valproic acid, carbamazepine. And then, again, for bipolar 2, you're thinking more along the lines of your lithium and lamictal as your primary maintenance. I'm not going to tell you that if you have somebody that doesn't want to deal with the side effects of some of those drugs, your atypical antipsychotics, again, they are approved as mood stabilizers. They're not bad options. And I should say all antipsychotics can be used as mood stabilizers. All of them can. The atypical antipsychotics that have gone through and done the studies are the ones that I'm going to go through today because those are generally the ones we're going to recommend. But all antipsychotics do have some mood stabilizing properties to them. Okay? All right. So the FDA, again, has come through and shown that they can be used as monotherapy, commonly are used as adjunctive therapy for other mood stabilizers. They are going to result in, again, a faster onset and better remission rate overall. And you know that when you're talking 1 to 3 weeks compared to that 3 to 7, I've said it a couple times now, this is where you're going to see this acutely used as a strong and heavy recommendation when somebody comes in and is manic. We know that if you look at the consensus guidelines that came out from 1999 to 2004, this was really when they started changing their viewpoints on antipsychotics in general and looked at including the atypicals as your first-line agents that can now be recommended in bipolar as well. Okay? Those that have actually gone and gotten approval specifically in bipolar depression are what you see here, Seroquel, Abilify, Latuda, and the other one that's kind of, I put in parentheses, in Symbyax. So Symbyax is a combination of olanzapine and Prozac. So you're only going to think of that one because of the antidepressant on board in your bipolar 2 patients or for bipolar depression because of the Prozac that's a combination there. Okay? So those are the ones that are FDA approved for depression. Okay, which of the following antipsychotics are approved by the FDA that are highly recommended for mania due to long-term studies demonstrating its efficacy? So who feels like ziprasidone is that answer? This goes back to your readings. Paliperidone, quetiapine, awesome, and risperidone. So yeah, quetiapine is your answer to that one. Quetiapine is something that has been used a lot in our bipolar patients. It's got a little bit more robust literature behind it and probably has a little more favorability, if I were to even say comparison, at looking at usage for efficacy, bipolar compared to schizophrenia. I'd probably say you'll see a little more efficacy across the board if you're using it for your bipolar patients, okay? This is showing up funny as well. Man, I hate this projector. I want to go back to the first replacement, sorry. So this, I don't know why that happens, I'm really sorry. You can kind of tell where the circles are supposed to be there, right? Yeah. They're close. Did it show up on your handout at least the right way? Okay, good. So olanzapine, I like this. This is an old study. This isn't something new. You'll notice I have it cited here. It was in Central Nervous System Disorders Journal, in our Central Nervous System Drugs in 2001. And I liked it because it specifically was looking at bipolar, and you'll notice there are differences with the side effects shown in bipolar in comparison to what you see in schizophrenic patients. Where, again, at that point in time, back in 2001, the expert consensus was looking at a lot of the literature and then kind of changed our mindset to looking at these drugs as first-line options. Okay? So you'll see that weight gain, sedation, not that surprising with olanzapine, is right up there. at the highest for weight gain. Quetiapine for weight gain is just behind it, similar as it was for what the Katie trial showed us in patients with schizophrenia. And then sedation is highest in your olanzapine and quetiapine back when this study was done. Ziprasidone and risperidone are a little bit less. The reason I have ziprasidone circled there is because it is a little bit of a difference from our patients that have schizophrenia we normally think about with that drug. So overall, I mean, I'm not going to specifically come down and test you guys on like this specific slide and saying comparisons, but I think it does kind of give you just the approach to say I'm treating my patient. I'm not treating the diagnosis, but the diagnosis can actually change, or the patient's presenting symptoms, right, can actually change the side effects, okay, our predominating side effects, okay. And then you'll notice here as well that the GI side effects that we normally will see with some of the drugs that, I don't normally think too much of GI side effects, but you are seeing a little bit more in our schizophrenic patients than you are seeing with your bipolar with ziprasidone. Okay, so we'll have patients report with schizophrenia, they will complain more about the GI side effects with ziprasidone than our bipolar patients do. So that's why that one's kind of supposed to be pointed out there too. Okay? All right, looking at clozaril now. This is still what we look at for our treatment refractory patients. Same situation as we look at this as kind of our last line option. I don't want to just jump into dosing clozapine because of all the side effects we've already discussed. But
Sure.
yes.
I'm sorry, I just have a question from the previous slide.
Sure.
Your circles.
Yeah.
What I have on when I printed out just is different than what you were citing.
Okay.
I don't know which ones are supposed to be circled.
Yeah, let me see. Oh, okay. So
They're way off on your
yeah.
thing up there.
Wow, that's really off.
Yeah.
Okay. So yeah, you're talking about the GI side effects
Yeah, and there was
and the aripiprazole too. Yeah.
also the one with clozapine, you said that it was Seroquel, not clozapine for the
Yeah, you lost some off the bottom.
Wow. That is all over the place, isn't it? Holy
Yeah.
cow. What you guys have is correct.
Okay, I just wanted to make sure that.
Yep. But so I was pointing out quetiapine, and I totally left off clozaril because it's not up there. Yep, sorry. Clozapine is another one that you will see. It's no surprise. You can kind of lump for metabolic issues and your thank you, and your sedation profile. They're almost always the same. If you look at them, they're very structurally similar, and it makes sense that those side effects would be the same. So okay.